Good morning, Dr. Rosensweet.
Good morning, Carolyn.
It is nice to see you, as it always is. Thank you for being here.
Thank
So,
you. Yeah.
yeah, thank you. And I will indeed welcome everybody who is coming up, and we'll get to you guys when you do. And I got lots of questions, so we're going to go ahead and get started. Um, my first question comes in, and our questioner says, when using a vaginal cream for vaginal atrophy, does it matter if it is an HRT cream or should I be using a bioidentical cream, as you've spoken of so often, being estriol? Was wondering your thoughts on this, please.
Well, I have very strong opinions about this. And one of the ways, if you give an analogy, and it's a little bit of a harsh one, but it does it does illustrate in a strong way. One of the ways they test whether a medication could be harmful to a human being is they'll put a drop of it in a rabbit's eye, in their conjunctiva. Put a drop of it right there. And if the chemical is harmful to the rabbit, we're going to see a red eye, irritation, inflammation occur. And when you think about it, that sort of drives home how important it is to not be sticking harsh chemicals into our body. So in the world of hormones, for the last 50 years, the most common hormone up until 2002 was derived from horse urine. Estrogens derived from horse urine. Only 50% of those horse estrogens were identical to what's in a human woman's body.
Right.
And a lot of women received that Premarin, that horse urine derived urine hormones, in combination with an artificial molecule called progestin that the human female has never seen that molecule. The human female saw progesterone. So if you're going to apply anything, if you're going to swallow anything or apply anything to the skin, one would tend to favor something that was native to the human female and not be messing with chemicals diverse from a human female's body.
Right.
That'd be my preference. For example, I take testosterone. I'm not going to want to take some fancy chemical version of testosterone. I'm going to want to take the same molecule that is in my body. Now let's talk about what you're applying to the vagina. Whoa, the vagina is a sensitive, absorptive surface. Whatever you'd apply to the skin, we get so much exposure of harsh chemicals all over the place to our skin. If you put one of those smelly dryer things, I don't even know. I never purchased one of those, but the stuff that these little paper-like things that they throw into a dryer to add scent or whatever they're doing there,
Softness.
softness, but it's got a scent to it.
Right.
What's the chemistry of that scent that you're putting on a shirt or a blouse, and then you're putting that blouse on your skin? What in the world would you want to do that for?
Marketing.
That scent is not native to your body. And
Right.
being a physician, and this is the difference between being a physician and being a patient, is as a physician, I've been exposed to 10,000, 100,000 human beings. I don't know just the story of my own self or one other. So many opinions appear on these social medias that they're the case of one. They're one person reporting their one experience. It's very disturbing to me because you talk to any physician, they have been dealing with thousands of people. They know the broad spectrum. And what I'm bringing up here is that knowing so many different patients, early on in my career, I started getting exposed to these people called sensitives. They're sensitive to everything.
Right.
You put one of those dry cleaning papers on them, they're chemically sensitive. They're going to get a rash or eczema or something fierce. And they are known in my world as canaries in the coal mine. If these people are reacting adversely to a dryer, I don't even know what you call those things.
You buy them in a box.
All the rest of us are getting equally poisoned.
Right.
We're
Ooh,
just not as sensitive to show it right away
right.
with a mass of hives, but we're all getting the same problem with it. We're all getting the same exposure.
So it's cumulative.
And it's cumulative, and that's the point. Instead of, when you drink a bottle of arsenic, you don't live till the next hour or something. That's it.
Don't remember it, right?
Because the toxicity is so fierce that we leave the planet. When you drink the hemlock, drink a little glass of hemlock, whatever that was that Socrates took to leave the planet Earth, the toxicity, but there's a lot of toxicity that we're exposed to one molecule at a time, and they add up and they're measurable. So I'm saying, would I apply something that's not a molecule to my skin? If I had to, I would, but I'd much prefer to apply the same molecule that was in my body.
Got it.
And then why don't you triple that when you think about the conjunctiva of a rabbit or a person, or why don't you quadruple it or multiply it by 82,000 if you're going to apply it to a sensitive surface like the vagina? Have I made my point? Why in the world would you want to apply something that's not bioidentical? That means identical molecule to what's in your body. And then you got to go one step further. When you're talking about bioidentical hormones that are applied to a surface like the vagina or the skin, you're talking about a jar or something, or a toppy click, or some kind of container of that bioidentical hormone. And whatever that bioidentical hormone you think you're applying to your skin, what's in the jar or the toppy click or the syringe or whatever your container it's been dispensed to you in, over 99% of it is not bioidentical hormone. Over 99% of it happens to be something called a vehicle. And most of what's dispensed, that vehicle, that 99%, is a very, very strong solvent. So when you're applying a topical bioidentical to your vagina, or a commercial Premarin, or a commercial, 99% of that stuff is a very, very strong solvent, because you don't get Premarin up into solution. You don't get estradiol up into solution, these vaginal estradiols, without having a very strong solvent, because the steroid hormones themselves, the hormones that come out of your ovary, are fat soluble. They're not water soluble. That's why what's in a jar or a toppy click or a syringe or however you're getting it dispensed, or in a pump bottle, over 99% of it is the carrier. And if it's dissolved, as most everything that's dispensed is, it is a strong solvent. Oh, what about that? What about applying a strong solvent? Well, I did the math once. I was encouraging my holistic menopausal patients to apply a quart of this stuff a year for 10, 20, 30, 40 years. Meanwhile, since I am always been a holistic or a functional medicine doctor, I'm detoxifying. I'm encouraging my patients to detoxify while I'm toxifying. Well, that led my son and I to invent and patent a organic oils formulation. If I'm going to apply anything to my body, I'd want to feel safe eating it or drinking it or applying it to my conjunctiva.
Yes, absolutely.
And that's what we did. We formulated oils that have been heavily tested. For example, one of the principal oils in our organic oils formulation, the Nabisco company did a tremendous amount of research on because they wanted to add it to their foods. Because oils can be important for foods. And they found that the oil, that the main oil in our formulation worked really well. And the only reason they didn't use it is what I heard is the world supply of it wasn't huge enough to give the Nabisco company the inventory it needed. Hello from Perth, Australia. My goodness.
Yeah, we have some. Yeah, so very quickly. Good morning, Susan and Sal and Jenny and Antoinette, Kathy, Marks and Kathy and Joanne and Iowa and V and good morning.
So when you're thinking of applying something inside the vagina, better you should not have chemicals. Better you should have organic oils.
Right.
And even saying that, of the 15 years or now that we've been dispensing hormones in these organic oils, even with oil, there's a certain small percentage of patients that are reactive to oils, natural oils. Even though they're organic and they're natural and they've been approved for food, that doesn't, there's a certain percentage of women that we have to alter that formulation because they get a mild allergy. So what you place inside of your vagina, as far as hormones go, take it all the way. Go to the organic oils. And there's a variety of hormones that are beneficial to the vagina. Estradiol is super beneficial to the vagina. Estradiol is super beneficial. And so is testosterone and DHEA. So depending on what the situation is in the vagina, when there's been vaginal atrophy from menopausal loss of ovarian hormones, that's what happens. You get vaginal atrophy. You get pain on intercourse if you're having intercourse. Mm-hmm. When you get a pelvic exam, the examiner can tell instantaneously that you're in menopause. If you're never told the examiner anything, all the examiner would have to do is look at your vagina and they would tell you what your estrogen level is. If you're not taking estrogen, they're going to tell you what your estrogen level is. They're going to say, oh my God, you're out of estrogen.
Yes, you're a lovely shade of gray.
It's a really reliable indicator of do you have adequate estrogen? Is there health to your vaginal tissue? So, okay. Yes, what you apply to your vagina really matters. And what I recommend is whatever it is, you're going to use hormones. That'll restore the vagina. Estradiol plus estriol, estradiol plus estriol plus testosterone plus DHEA, whatever. Estradiol alone is going to do great things. But have it in a vehicle, a delivery system that is healthy for your body.
Right. It's like putting perfume on your skin, kind of, in a way, Yeah, I used to get teased about that by my family. They're like, she's putting it on her clothes. Somehow I knew, I guess, that it wasn't good to put on the skin.
Well, think about it. Here you go again. If you feel uncomfortable about putting a drop of it in your conjunctiva, in your eye, you want to really think twice about you want to put it in your vagina because it's going to go into your body.
Yeah. Oh yeah. Okay. Well, thank you for that answer. And
I'd like to comment on one of the questions here.
Please.
I'll read it out loud.
Okay.
Carolyn, you look pretty today.
Aw. I was going to make a comment on that question too. No, I'm just
Can
kidding.
you handle it?
Not really, because I'm me, but I really appreciate the compliment very, very much. Thank you, Kathy. I appreciate that. I do. I attribute that to certain things that I'm taking, to be honest. And with that compliment, which I will definitely take, I will move on to question 2, which is, and thank you, Susan. Is there a standard?
Carolyn, can I interrupt you for a minute?
Sure.
A very interesting question just popped up from Antoinette. Can
Yeah.
50-50 bias applied to the vaginal area cause too much estrogen in the system? It all depends on the dose. 50-50 isn't the issue there. 50-50 is just describing how much estriol is in there, 50%, and how much of that formulation is estradiol, 50%. What
Right.
really matters is the number of milligrams of that bias. If you take, and you can make a formula that's too strong and you're applying too much and you'll be applying too much estrogen, you can be overdosed with estrogen. So what's missing, Antoinette, is how many milligrams is actually going into the vagina. You can under treat and not put enough bias for treatment in the vagina and still help the vagina, by the way. Or you could take too many milligrams of bias, 50-50, and give yourself an estrogen overdose, in which case you'd probably get symptoms of estrogen overdose. And Carolyn has downloaded this little handy chart which describes symptoms of too much estrogen in there.
Yeah, and I can raise it up so that everybody can see it.
Yeah, so it's really about how much you're applying there.
It's interesting. I believe that this question is from Antoinette. I might be wrong, and I apologize if I am, but it kind of ties into this. So it says, and thank you for answering that. Is there a standard for prescribing biotestosterone? Is it 1 or 2 mica? And do you feel that the submucosa is best for absorption? So we visited that a little bit, I think, in our last answer. Is this a question that you understand?
No. I don't.
Okay.
Thank you very much. Let's break it down to the first part. What was the first sentence there?
Is there a standard for prescribing bioidentical testosterone?
Absolutely, there is. And, there's a variety of ways to my favorite and only way that I accept taking bioidentical testosterone is topical. Testosterone is unacceptable orally. It's risky for the liver. And you can't even get it, so no worries. You're not going to be able to get oral testosterone.
Right.
And topical is the way to go. It absorbs beautifully. I know that pellets are offered. I know injections are offered. I am not a fan. Daily topical application of testosterone works fabulously. How do we know that? Because we're testing every single one of our patients with the 24-hour urine hormone test. We can see how much is going into their body, and then how much goes into your body. Well, there are reference ranges. For example, I wouldn't recommend that a woman take so much testosterone that she's got levels higher than a 20-year-old does. Not at all. You don't want to be messing with excessive levels of hormones. These are the most powerful biochemicals in our body. We've learned harsh lessons from excessive dosages of hormones. They're historic in the world of pharmacology and in medicine. Don't do it. Don't try and take more than a 20-year-old has, for God's sake. And so these are numbers, but ultimately the numbers, you want a prescriber who knows their numbers, and it's going to be based on the dispensing method. We know the numbers for this. But ultimately, it's going to come down to, finally, how do you test out? Yeah, you're applying testosterone to your skin or your vagina. Well, what are the ultimate 24-hour urine hormone test results? We can tell if you got too much or too little. So there is very distinct parameters. And Antoinette has told us that it's 2 milligrams of 50-50. That means she's getting 1 milligram of pure estradiol, 50-50, 50% of 2, 1 milligram of pure estradiol. And she's getting 1 milligram of estriol, 50-50, bias 50-50, 1 milligram of estriol. But however, of that estriol is only 1/8 as potent as the estradiol. So what she's getting is if she's taking 2 milligrams of that bias a day, 50-50, she's getting 1.1 milligram of estradiol potency and 1/8 of estradiol potency. So she's actually getting 1.125, or let's say 1.1, that's what it rounds out to, milligrams of estradiol. Well, is that too much or too little? Well, it depends how well you absorb it. As far as numbers go, 1.1 milligrams of estradiol equivalency, that's your equivalent, you got potency equivalent to 1.1 milligrams of estradiol there. That's going to be a pretty good dose for most women. Average in my practice, 1.7 milligrams of estradiol equivalent. But average doesn't count in the world of humans. Doesn't count for too much. Really, in my practice, and we've done studies on this, some women do really good on 0.8 milligrams applied. That's less than the 1.1 milligrams of estradiol potency. Other women need as much as 2.6. 0.8, 2.6, average 1.7. So Antoinette, I can't say where you are. Are you at 0.8 or are you at 2.6? Now that's applied to the skin or applied to the vagina. What really counts is how's your absorption. It matters. You got to take two things into account. What are you applying to your skin or your vagina? However, what are you absorbing? So the final answer there is determined by 24-hour urine hormone testing.
Oh, yeah, 24. Yeah, definitely. And she goes on to say, do you feel the submucosa is best for absorption?
Now, that's what I didn't understand. You can't apply something to the submucosa. You can apply something to the mucosa. What is mucosa? It's an internal lining. Like our bodies are lined by skin. Our face to the external world is our skin. That's the interface. And that's a lining. That's an external lining. We have internal linings. The vagina is one of the places we have internal linings. The mouth is another place we have internal lining. This mouth in there, that's called the mucosal surface. It feels different, it looks different. And inside the vagina, that internal lining is sort of like skin, but it's not. It's got some refinements there. And that's a mucosal surface. Submucosa, you got to stick a needle in something to directly access the submucosa. But anything you apply to the mucosa is going to wind up in the submucosa. So that's why I had a little bit of, well, technically speaking, what are they talking about there? And so read the next sentence.
It really was just that. It said, is there a standard for prescribing biotestosterone? Is it 1 or 2 mica? Which that one kind of confused me. But going on to say, and do you feel the submucosa is best for absorption?
Well, I would replace the word submucosa with mucosa.
Okay.
That's what threw me a little bit.
Got it.
And there is no terms. There's micrograms, but testosterone is not dispensed in micrograms. Testosterone is dispensed in milligrams. And again, it varies woman to woman because there's what strength you apply to your skin or your mucosal surface, such as the vagina or the inside of the internal labia, the vaginal lips, the inside of the inner lips is actually a mucosal surface too.
Got it. And then there's
and so it can be applied there. It does interfere with 24-hour urine hormone testing, so we tend to not apply things there. But at any rate, it varies. Some women, you got to do 0.2 of a milligram of testosterone. Some women, you do a couple milligrams of testosterone. Varies woman to woman. The final answer is what alleviates symptoms. And then the final answer is, yeah, once you figure out your dose, that's symptom alleviation and tissue repairing, you do a 24-hour urine hormone test to make sure that you're not taking levels that are stronger than what a 20-year-old would have, or are not levels that, yeah, you feel a little better, but they're too low. They're showing up in 24-hour urine as too low. You're not going to benefit in the long run. So the 24-hour urine is the final arbiter there.
Got it. Got it. Well, thank you very much. And she sent, I meant milligrams brain freeze. So we figured that one out. Okay. Thank you.
What we do is as far as testosterone or biased or progesterone is we start with a low dose, like someone who's testosterone deficient. They got all testosterone, like all these hormones, is so powerful that if you're testosterone deficient, you're going to have symptoms. Most women, not all.
Yeah.
Now, I can tell you this, 100% of human women are going to be testosterone deficient by 3 years with no period. Majorly. Enough to affect your whole life if you don't replenish it. Because testosterone is critical for the maintenance and health of your muscles. So when you look at women or men in their late 70s and 80s and 90s, their lower extremities, oddly enough, their thighs and their calves look super thin. What? What happened? How come they got so thin there?
Yeah.
Because they lost muscle. Or if you look at a lot of women and you just flap the tricep area and you see in young women, you see a firm muscle there called the triceps muscle. In elderly women, in menopause, you see a floppy. The muscle has been replaced by fat. What's the consequence of this? You lose muscle in those lower extremities. You're going to make a transition to cane, then walker, then wheelchair. You're going to lose the muscle that supports the bladder, and you're going to get incontinent of urine. You're going to not be able to control your urine, so you get into adult diapers. As a physician, because I see women of all ages, I see the 80-year-olds and 90-year-olds who haven't been treated. And they are losing their urine. They're wearing diapers, adult diapers. They're transitioned to canes, walkers, and there's a moment where even walkers won't do it. You got to move to the wheelchair. And this is the defining moment when a lot of women do something that most women do not want to do, leave their home and lose their independence. This is how crucial testosterone and right levels of testosterone are. You get sarcopenia. And the interesting thing is there's a very, very high percentage of women in the perimenopause that have already lost so much testosterone they're on their way to sarcopenia. They've lost their libido, they've lost their drive, their mood has changed. Testosterone is not a male hormone. It's a human hormone. And women, you need it as desperately as men do in andropause. Men in andropause lose their testosterone. There's a desperation there because if you don't get it, you're not going to be taking your daily walk or dance Very rare humans can escape from exercise alone. They need the androgens. They need testosterone and DHEA. So once again, I've gone down pathway B
16. OH.
or H,
Or
deep into, but the subject is so important.
it is, and it's fascinating.
And I want to really emphasize that a woman's ovaries puts out 4 amazing, powerful hormones, and then a woman's ovaries, like a man's testicles, stop putting out. I referred a 40-year-old man to our expert in testosterone in males yesterday. 40 years old, showing signs of diminished testosterone. So, at any rate, that's why I went down that pathway.
And
then, what do you need as an individual? You need the right amount for you. Well, there's ways that we know how to get you there. We start with low doses and we gradually increase. Sometimes we push you to testosterone overdose. What happens when you get testosterone overdose? You get cranky, you get too testosterone-ish. You get a little mean, and your people are going, calm down, will you?
I can't.
I was just asking you to pass the salad.
Right.
You didn't have to chew my head off. Or you'll get oily skin, or you get pimples, or you get hair on your mustache area or on your chin.
Yep.
So there are symptoms of excessive testosterone, but ultimately you want to do this with an expert who knows how to help you dial into your optimal dose and then test you with the 24-hour urine hormone test. Notice I'm not mentioning any other test. I'm saying the 24-hour urine hormone test.
It is something that I'm going to be bringing up next week. Yeah, for sure. I have that written down. I know that for some women, it's very difficult for them to get testosterone. So we will visit that definitely next week. Yeah. Well, Antoinette again says, you're so entertaining, Dr. Rosensweet, educational and entertaining. And we're always saying this about our dear Dr. Rosensweet.
I would like to add that my grandfather's brother, my great uncle, something like that. He was in vaudeville, and he was in the Friars Club, and he took great pride in that. So, Uncle Ben, wherever you are,
a huge thank you for being in vaudeville. Okay, so moving on.
One of your relatives was obviously in vaudeville.
Many.
Obviously. You got that gene, obviously. And you married Daryl, and Daryl's in showbiz.
Oh, he is indeed. Yes, he is. Yes,
so
he
you can't really escape your heritage and your marriage.
1 foot in the arts, 1 foot in medicine my whole entire life. Weird, but that's the way it's been. And for me, I love it,
Yeah.
And I'm very blessed to have you and very blessed to have these amazing women and men. You men are not forgotten. So moving on to question number 3 in my vaudevillian way. Hello, Dr. Rosensweet. I am new here and I really appreciate you. I'm 50 years old, 2.5 years into menopause. Prior to hormones, I had muscle weakness, cognitive problems, inability to concentrate. But oddly, after starting my hormones, I felt awful. I always had really bad PMS, and with hormones, felt that horrible PMS once again. Prior to hormones, my estrogen was at 48, and it surely must be higher now, but I've stopped my progesterone. So how could it be that if my estrogen is higher now, due to the hormones I've been taking, I'm feeling worse? Osteoporosis runs in my family. I know I need hormones, but I am not tolerating them well at all. So help, please.
Good question. There's a certain percentage of women that go into menopause, their ovaries stop producing hormones. You can give them something really broad-based that's not accurate, and they do better. And that went on with Premarin and Prempro for 20, 30, 40 years. The women who got these average doses of horse urine-derived estrogen, they did so much better than their compatriots who were not getting treated, including having less risk for breast cancer, heart attack, and stroke. So a lot of women do well with just the average or a guess or somewhere in the ballpark. However, caveat, that's not such a huge percentage. There's a certain number of women who go into menopause. It's a piece of work to get it right, because every single woman varies from every other woman as to how much she needs of anything. We're talking about 4 hormones here, if not thyroid as well. What the internal balance is, how sensitive she is to anything you give her, and the amount of each one of those 4 and how you get to balance those and how you deliver them to her and what her response is to anything you give her. The level of individual variation is rather astronomical. No problem. Once I got almost right out of the gate that the only thing you had to do is individualize it woman for woman. You come up with starting doses of estrogen and progesterone and testosterone and DHEA. You start low, you gradually increase, you play with the symptoms, you dial it in, you vary it, and you test by 24-hour urine hormone testing. And really, the moral of the story is, although there's a certain percentage of women that it's pretty easy, you just almost give them anything in the world that has the name hormone on it, and they do pretty good. But these are rare.
Yeah.
In the menopause method, we plan to spend somewhere between 3 and 20 hours the first year in the dialing in process. 3 minimal. We'll do a minimum of 5 consultations. We even price it so that there is no limit, because we know after 25 years that you got to put the time in.
Yes.
Some situations do not require a lot of time. Others require a tremendous amount of putting things under the microscope and balancing them correctly and testing and retesting. Doesn't matter. From my vantage point, you just individualize one woman to the next. So when you make the statement, questioner, that you know you need hormones, yeah, you're a couple of years out of your last period, you absolutely need hormones. History of osteoporosis, that's from low estrogen and other things as well.
Right.
You absolutely need the treatment, but what happened to you, from my opinion, is someone approached you with not the level of accuracy and precision and individualization that is required. So you got overdosed, you got the wrong balance, you got underdosed. Something went wrong, because the only acceptable thing in treating a woman in menopause is that she feels better.
Yes.
And she alleviates a lot of the very uncomfortable symptoms that she has. That's the only thing that's acceptable. And if she's not getting alleviation, something's wrong. Something's wrong with the dosages, the balance, the type of hormone you're taking. So that's the art, is we put in the time, we turn on the microscope, so to speak, the metaphorical microscope, and we figure out and individualize every single woman. So I would say, although you were discouraged right out of the gate, and I've seen this so many times, there's women who've gone to 1, 2, 3, 4, 5 different healthcare providers and still haven't figured it out. And they get very discouraged and they think there's something wrong with them. Well, here's one of the problems out there. You go to a neurologist or an orthopedic surgeon or a cardiologist anywhere in the United States, if not the whole planet Earth, you're going to be dealing with a uniform body of knowledge of physicians and nurse practitioners who have specialized They don't try and be a general practitioner. They zero in on the heart, or they zero in on the bones, et cetera, et cetera, et cetera. Because that's the only way you get good at this stuff. Specialization. As much as I resisted it as a young doctor, I started realizing that it was impossible to get my arms around the whole field there.
Yeah.
I couldn't, I was a jack of all trades and couldn't get good at any one of them because I couldn't study. I couldn't see enough patients. And what you're dealing with in the world of menopause, for reasons, is this very unusual medical situation. You've got very few people who specialize. Most people that you're seeing, they have these broad-based practices, and menopause is a small part of it. And they don't have the time to do the amount of education and get the mentoring. You want to be a cardiologist, you want to be a gastroenterologist, you go to 4 years of medical school, 1 to 2 years of internship, and you go into a residency program, and you're out of, you're in your 90s by the time you're ready to hit the streets. Just
It's
kidding.
like my father.
Yeah, but you're certainly not in your 20s anymore.
Mm-mm.
You've gone through 3 to 5 years of specialization in which your education continued. You were in a residency program. That means you were mentored on a daily basis by physicians who had far greater experience and were masters in the field. And you did that for years. And that's how you became a cardiologist or a surgeon or a gynecologist or any specialty you can name. You go to a gynecologist, the amount of training and mentoring they have is staggering, or an orthopedic surgeon. And you know why it's staggering? Because it takes that much to get good. But because the whole medical profession got so terrified from the Women's Health Initiative, which was false information. We've gone through this before, and I'll go through it again as much as people want to ask.
Oh, it's so important.
The whole world of treating women in menopause got totally stunted. In fact, it had a blow like has taken place in no field of medicine. No field of medicine has been impacted like menopause. This false scare went out, and who wanted to specialize in treating women in menopause? So many physicians and nurse practitioners won't even dream of giving a woman hormones because they're still stuck with the false information of the Women's Health Initiative 2002, even though that original study committee retracted that information in a 2017 follow-up study in which they said after 18 years of follow-up, there is no increase of breast cancer, heart attack, and stroke. No increase. In fact,
right.
The data is there's less risk. And,
yeah.
And last night, through an A4M post, I was linked up with an article. In fact, here it is. There's a humongous protection from Alzheimer's and neurodegenerative disease in women who are treated with hormones versus women who are not. Oh, Alzheimer's, dementia, neurodegenerative disease like Parkinson's, ALS, all that kind of stuff. Oh, diminished incidence of women who are treated with hormones. And not only that, they state that the higher tech, the more precise the treatment with hormones, the better off, the lesser risk there is. So I know I'm drifting a little bit there.
It's so important, though.
Is you got a field that's so complex. I've been studying it for 25 years. I learn new stuff every day. And you want to go to someone who's taking this powerful. If we're playing with fire here, folks, we're playing with the most powerful biochemicals in our body. Like, for example, you don't want to buy insulin over the counter and treat your diabetes. Well, you can't anyway. You need a prescription. But you want a living master. You want a doctor who has been treating hundreds and hundreds of diabetics with insulin and with the various oral medications. That's who you want to go to. You don't want to go to someone who went online and learned how to work with insulin. Oh my God. Well, you don't want to do that with any of the other hormones either. They're very strong, and you want to get it right. And you want to get insulin just perfect. If you're a diabetic, you want to get it right. And you want to deal with someone who loves treating diabetics, like endocrinologists. They love treating diabetics. And so does many internal medicine doctors. They have enough training, but the specialists in diabetes are the endocrinologists. You want to go to an endocrinologist who thinks diabetes is the most fascinating, and they chose to specialize as an endocrinologist into treating diabetes. That's who you want to go to. You're playing with fire when you're playing with these diabetic medicines. You want someone who knows how to dial that in with tremendous excellence. Well, I'm saying it's not as critical as insulin, because insulin, you could really have adverse consequences.
Ooh, yeah.
But it's close. These are very powerful, powerful biochemicals. That's why they're so great.
Well, right.
That's why they do so many amazing things.
Yes.
But you want to deal with someone who's specialized in it.
Right. V just asked, she said, could you post that article so we can share it? And I don't know if you can or if you cannot. We certainly can put it up on the CBHRT and what's happening in Washington group. So if you want to send it to me, Doctor, or I can post it there.
I will.
Okay. So V, yeah, I'll send you that link.
It's just amazing.
Yeah, there's a lot up there on that group, and a whole bunch happening, and I'm happy to post that for sure. Thank you, Dr. Rosensweet.
Oh yeah.
Very, very much. It's so important. Okay. No, I mean, this interview.
Another mild-mannered day with Carolyn and Dr. Rosensweet.
The Carolyn and Dr. Rosensweet show that I happen to love. And we've been doing this a long time, and I still love it every single time we do it. Moving on to question number 4. Have you heard of women being nauseated, having heartburn, and increased heart beating upon starting hormones? I'm using creams. I'm not feeling that this is in any way attributed to my taking DHEA, but something is very off as I'm not feeling very well. I also tend to get dizzy and lightheaded, kind of like a weird vertigo thing, and I'm not really sure what to do. I'm wondering if you've heard of this and if you can give us your thoughts.
Well, again, the general principle is when a woman's in menopause and she's having a list of symptoms and she goes for treatment, there's only one thing that is acceptable as an outcome. Everything feels better and functions better. If everything does not feel better and function better, something's off. There's a lot of things that can go off. A lot. You can have the wrong hormones, not optimal and optimized for the woman. You can have the wrong carriers, not optimized for the woman. You can have the wrong dosages. Oh my God, can you have the wrong dosages? You can have the wrong method of application. You can have the wrong balance between estrogen and progesterone and testosterone and DHEA and thyroid. And you can have underlying medical conditions that can influence all of this. You can have receptor site problems in that your receptor sites are in trouble. And there's a wide variety of reasons that they're not in trouble, that they can get in trouble. There's a lot of moving parts. So what you want is to go to someone who's willing to turn on the metaphorical microscope, zero in on you, and figure it out together. And there are some, I don't know if it's 10% or 20% of all the women over 25 years that I've worked with women in menopause. I'd say there's between 10 and 25% of the women that it takes time. It takes figuring it out. Sometimes we figure it out day by day by day. I listen to what's going on with the woman. I come up with an idea. I think you should adjust this. But the only thing is, the proof's in the pudding. So I connect with her the very next day and I go, how did that work? And she says nothing. Got worse.
Right.
Oh, wrong idea. Wrong idea. But that information, if you keep following that bouncing ball, there's been 2 cases over 25 years that I have not solved. And both of them I wanted to continue, but the women thought, no, something's wrong with this process. I'm leaving. I thought I could have solved those. And sometimes it runs a lot deeper than hormones. That's the thing. And sometimes, for example, I'll give you a classic example.
Okay.
There's this thing in nature called health, and there's things in nature in our physical bodies called illness.
Right.
And for years, in my early years of being a doctor, I thought illness and symptoms bad. I'm here to fix symptoms and illness, otherwise known as symptoms.
Symptoms.
Illness
Those
and
symptoms.
symptoms. Illness and symptoms equals symptoms. And that didn't work. That didn't work in way too many cases. So I went back to the basics, and I thought, maybe there's some reason for this sickness or these symptoms.
Mm.
And I ultimately discovered this principle, that there's nothing like an economic crash or an ecologic crisis or a relationship crisis or an illness with symptoms to stop the world for people. Stop us in our tracks. And there's a purpose behind it. So you could call illness bad or symptoms bad, but what I've come to discover is it's the ultimate tool of nature to stop the world for an individual. Stop their world. And there's a purpose behind it. We're getting some unusual background sound. Can you hear it, Carolyn? It's like
I did for a second.
Yeah. So the stopping of the world has a purpose. Quote, nature, end quote, in my opinion, is trying to get our attention. And it wants us to ask the question, what's going on here? That's the purpose of stopping our world. Something's not right here. What in the heck is going on? That's the purpose of illness. And the problem with illness is it wants the real answer. It doesn't want its final answer is this is not something like this is a vitamin C deficiency.
Right.
It's not enough of an answer. It's not enough of an answer to say that this is a hormonal deficiency in most cases. For example, a woman or a man can have so much stress in their life that it's depleted our hormones. Well, we could administer hormones, pour them in one end and watch them go into the toilet and collect the 24-hour urine to measure the hormones going right on through. No. We don't want to try and address these issues called better living through biochemistry. So, for example, if a woman has a tremendous amount of stress in her menopausal life, and she's unconscious about it, and she's not dealing with it, and she's got these rip-roaring emotions or thoughts or relational issues or life issues, and she's having all kinds of symptoms of menopause, the remedy is not to give hormones.
Right.
That's the only thing that you're doing. Better living through biochemistry.
Right.
No. Ultimately, nature's trying to stop your world to get you to say, well, what's really going on here? Well, I haven't been speaking up in my marriage for 30 years, and I'm now living at the consequences of not being honest, not being authentic. So sometimes We go to treat women with perfect rationale and they test out normal, but they're still having a lot of symptoms. Well, there's a reason for that. Nature is not going to tolerate just dealing with symptoms. The homeopathic physicians and the homeopathic knowledge base talked about that. They said their warning to us as physicians was, don't just be treating symptoms, folks, because if you whack down a symptom, you're going to play whack-a-mole with it. And the problem is you're going to take away a symptom from someone, which is their natural mechanism to pay attention to what in the heck's going on here. You're going to take that away. You're going to drive something deeper, and it's going to reappear sometime later, something worse than it was initially.
Yes.
To simplify this, you go into midlife, and if you think that you're going to repair midlife by better living through biochemistry, it's risky business. There's been times that I've really challenged myself. I said, I've just listened to this whole woman's story. She's very upset. She can't sleep. She's very agitated. And she's in an abusive marriage, physically abusive, sexually abusive, harsh. And I'm going to help her feel better by taking away her symptoms, when the power she needs is the breakdown of the pain to start talking and start speaking out loud. You better stop abusing me verbally, emotionally, and physically, or there's going to be consequences. I'm giving you gross examples. There's far more subtle examples.
Yes.
There's a lot of women that you balance the hormones. It's a tremendous service. It's the basic mission of the menopause method. Rebalance and replenish those hormones, and women who've fallen off of a cliff and aren't able to live well, you replenish their hormones and they got all the power they need restored so that they can handle their life issues very well as well, and their professional issues and all the issues. So that's our main mission in the menopause method. I never want to diminish that. Hey, listen, we replenish those hormones. That's where we start. And that can empower a woman so excellently that she'll take care of the rest. But in some instances, we try and administer hormones and it's not working. And what I start asking myself, am I trying to override some very important information? Like, for example, is a woman got too much day-to-day worry going on, and she's too worried about everything, and that what she really needs is a combination of hormones plus wonderful therapy to learn how to deal with the anxiety and depression that she's not dealing with, or what's underneath it, the fear, sadness, anger, shame, and guilt that's leading to excessive thinking, excessive worrying, excessive worrying, excessive worrying. So you don't just treat with the hormones. You say, here's hormones, and go shopping for a wonderful expert who knows about the emotions and mind, because you need to do that heavy lifting. You need to do the great work, what I call the great work. The great work of being a human is deepening and broadening and becoming more accepting of self and life and healing one's own emotions and mind so that you become a better human being. And there ain't no amount of hormones that are going to correct underlying anxiety, for example, if that anxiety is tied to the great work you need to be doing.
It's a big subject. You often talk about the elephant in the room.
Yeah.
And you and I visited that when I met you very, very early on, some 3 years back. And it's a really good subject, I believe, to spend a good hour on talking about.
Because that would be a good idea someday, Carolyn. I agree with you. And the moral of the story is we're here on Earth for reasons, and part of it is becoming wiser, more effective, kinder, more accepting, more golden rule. more loving of ourselves and others, more compassionate, more contributory. This is the great work. And there's some mechanics of that great work. It's really helpful to acquire skills, information, tools, and support with people who understand they've made their life work, the emotions and the mind. There's a body of knowledge and tools out there that is absolutely phenomenal. And there's professionals who've devoted their life to assisting people to work with their mind, their emotions, their relationships, their marriages, their businesses. Seek these people out. And they're all over the internet. And yes, there's some people that are nice people and who are professionals, but they don't really have the tools and the firepower to help someone. But they have the firepower to listen. That can be helpful. But there's some experts out there. There's some masters. 2021, you got access to a body of knowledge and information and tools about the emotions and mind that is staggering. You
Absolutely.
can. Yeah.
Yeah.
So we encourage you to, yes, if you're in menopause, take hormones. Absolutely. And we're getting a message that our audio is gone.
From one person. I haven't heard that from anybody else.
Yes, if someone else cannot hear us,
We're also,
Jaylee is saying our audio is gone. Does anyone else think our audio is gone?
we're at 8:03. Are you okay
Oh
with
my God.
I know, huh?
Oh my God. It's time to say sayonara for the day.
You're the David Rosensweet and the Mr. Rogers combination, which is so beautiful. It's time to say goodbye. Aw. Hate that. But anyway, I think that the audio's okay, but we're done. Oops. Playback's going to come up, though, and I hope everybody will watch it because this has been a really, I think, really good interview. And I really appreciate your answers and all the questions that I get.
And you'll post that article because I just sent it to you.
Oh, you bet I will. Yes, sirree, Bob. I've got an hour before I have to go to work, and I can do that.
All right. So once again, it's a pleasure, Carolyn. And until next Tuesday.
That's right. Yes. So, Dr. Rosensweet, thank you so much. All the women and the men who have come up, thank you so much. Got your questions? Post the article. We're going to keep it moving and just continue to help as we can do. 1 minute at a time, 20 of you at a time, however many at a time we can do, we're down. Okay? Have a really, really great weekend.
Bye-bye, everybody.
Bye.